But now, do resistance tests really work? That becomes an interesting question. So we started looking at the value of doing a resistance test for people who are HIV positive. Part of the reason why we wanted to do this is because it is routine care in high-income countries, and we want to say, okay, everybody should get a resistance test, but we can't just say when it is extremely expensive and some other countries might not be able to afford it. So before we start investing in that, we need to know how well it works. So what we found was that for people who have started treatment and who have treatment failure, so the drugs aren't working anymore, if you do a resistance test, determine what drugs they are resistant to, and give them a new treatment, and then you reduce their risk of virological failure by about 30%. That was a good thing. But unfortunately, we only have data on people who have started treatment and who have failed treatment. None of the studies included people who were treatment naive, people who were starting treatment. So none of them really had pre-treatment drug resistance that we are interested in. So luckily for us, Ontario created the opportunity for a beautiful natural experiment. It turns out the first resistance test available in Ontario came in around 2005. In 2014, Public Health Ontario made it a matter of policy that everybody who is diagnosed with HIV should get a resistance test. So based on this new policy, we were able to look at the data from 2005 to 2014, when the policy was initiated, and compare that to the data from 2014 to 2018 when we did this study, and determine whether there was any impact of this new policy on the population level. So we looked at the outcomes of mortality, hospitalization, and emergency department visits. So what we found was that 2-year mortality reduced on the population level thanks to the implementation of the new policy. But there wasn't much difference in terms of hospitalization or emergency department visits. But at least on the population level, this is a good thing, right? But now we ask ourselves, well, what about on the individual level? How does this work on the individual level? So there is some data which we are still working on, and we looked at the association between resistance testing and death, and also resistance testing and viral load. So I'm just going to talk about resistance testing and death. So basically what we found was that older people were more likely to die with or without the resistance test. That is, not unusual. But however, even with the resistance test, people with less than university education were more likely to die. Right? Again, this is doubling back to all the social determinants of health that we've mentioned. Even with the resistance test, people with low levels of education were more likely to die. Poor adherence also showed up, and this can be expected, right? Adherence is likely one of the main causes of drug resistance. And even if we do a test and we determine what drugs you're resistant to and we give you the appropriate drugs, if you don't adhere correctly, the treatment still will work, right? So adherence is a key piece of appropriate HIV outcomes. People who inject drugs are also more likely to die, and that has also been mentioned earlier on. And then we found that the people who were less likely to die were people with higher incomes, right? Suggesting that a higher income or a higher socioeconomic status is favorable, right? As it indicates more access to resources, knowledge, and all the other things that ensure longevity. So the next thing that we have to do in terms of fighting drug resistance is adherence to treatment. And I have shown you empirical evidence that even if we are doing resistance tests for everybody who is starting treatment, if they don't adhere to treatment, they won't reap the benefits of the resistance test, so it will be a wasted investment, right? And in order for adherence to work, we have to implement all the strategies which we've talked about, including education, reminder systems, support groups, and I also mentioned virtual care and mobile health in my previous presentation. So the next thing is also choosing the right regimen, right? Some of the evidence suggests that in addition to doing the resistance test, the test itself has to be interpreted by an expert. And somebody who is knowledgeable about the medication and the side effects should be responsible for choosing the right treatment for the person who has drug resistance. And this should also take into account the socioeconomic factors and the person's ability to actually adhere to that treatment and follow up with their care. Now, we also have newer antiretroviral drugs which are making it somewhat easier to combat antiretroviral drug resistance. So some of these drugs are very good, and the two main advantages of the drugs is that they have a higher resistance barrier. So people are less likely to develop dolutegravir resistance. And with some of the older drugs, the biggest problem was that if you have resistance to one drug in the class, you develop resistance to all the drugs in the class. Whereas some of the newer drugs, if you have resistance to one drug, the resistance stays with the one drug, and you can use other drugs from that class as well. And then now we also have long-acting treatments which are injectables as well. So this removes the problem of adherence. Instead of having to take a pill once a day or twice a day, you go into the clinic every 2 or 3 months and you get an injection. So that sort of helps with adherence, and it reduces problems of drug resistance. The next bit is patient education and support, right? People need to understand what the implications of drug resistance are. Drug resistance not only limits your therapeutic options, but it also makes you more likely to transmit HIV because you have a higher viral load. And it's even worse if you're transmitting a resistant strain to somebody else who has HIV, right? It complicates the epidemic in several ways. So patients need to be educated on these things, and they need to understand why it's important for them to adhere to their medication. So in terms of future directions, there's ongoing research to understand drug resistance, there's ongoing research to develop new therapies, understand the mechanisms of drug resistance, and create new treatment strategies that will enhance our ability to manage and prevent resistance effectively. So all this work I have done has led to a number of things. The first is when we did the systematic review, we were particularly interested in understanding the context of drug resistance. Who has drug resistance? Why do they have it? What are the characteristics of people with the highest rates of drug resistance? So in those studies, we tried to draw information on where these people lived. Was this a community-based study? Was it a hospital-based study? Are these high-income people or low-income people? What is their level of education? What kinds of tools were used to calculate the sample size for the study? How was the data collected? How was drug resistance interpreted? And based on the work we did, we found that a lot of papers that report on drug resistance really do not report this information. So you pull that data, and it's hard to contextualize the prevalence of drug resistance that you're seeing. Right? You don't know if this was taken from a random sample, or it was taken from a high-risk population or a low-risk population. And that creates challenges in pooling data and in comparing data across jurisdictions. So we found that that was problematic. So one thing which we did, which is particularly interesting, for example, here I show the number of studies that reported on the level of education and income, right? Only 6% of the studies reported on the level of education, and only 3% reported on the income of the participants in the study. And I have earlier shown higher up that level of education is an important factor in your outcomes if you have drug resistance. I have done the same for income as well, right? So if studies are not reporting this information, then it makes it challenging to interpret the information that we are seeing. So what we did was we went on to create a checklist for studies that are reporting HIV drug resistance prevalence or incidence, and that's what the checklist looks like, and it exists on this website called Cedric HIV, and we have translated this checklist into 5 languages. There's French, there's Portuguese, there's Chinese, there's Spanish, and there's Italian. And if I find people who are willing to help me translate into other languages, I'm more than happy to have a go at it and increase the number of languages. So far, it has been widely accessed, and a number of people are using it to report studies in a more comprehensive way. So, understanding HIV drug resistance is vital for effective management, and by focusing on adherence monitoring, this is key, adherence monitoring and personalized treatment, we can improve patient outcomes and combat the challenges posed by resistance. Thank you.